during my talk at the CaReMe-O conference in Barcelona in March, I will, of course, highlight the achievements that have taken place during the last, let's say, 8 years, 7, 8 years. Everything started on the 17th of September 2015 with the Emperor outcome trial made public at the EASD in Stockholm, showing that an SGLT2 inhibitor, by definition glucose-low medication, can actually improve the prognosis of your patients. And after that, we have had a lot of other medications showing also similar results. So now we are in a totally different situation. We actually have the means to treat our patients with diabetes and especially kidney disease, which is a driver of cardiovascular disease. And I will, in my talk, I will definitely set the background. Why should we treat these patients? And I can tell you now already that the take-home messages will be: kidney disease in diabetes is common. The consequences are grim. We need to take action. If you would ask me about 10 years ago, we wouldn't have had much more than the standard of care, which is basically 5-finger rule, optimal glycemic control, optimal blood pressure control, optimal lipid control, stop smoking, and the use of RAS blockers, which is fine. The whole 5-finger rule, absolutely fine. And we can improve the prognosis. But there's a lot of, or let's say there was a lot of unmet need that now can be addressed with the newer medications. SGLT2 inhibitors, the non-steroidal mineralocorticoid receptor antagonist, finerenone, and GLP-1 receptor agonists. So we now have a totally different situation. And I will, of course, highlight this. So kidney disease in diabetes, common. Consequence grim, we need to take action. 5-finger rule. And now the 5th finger. Actually, it doesn't only include ACE inhibitors, but also SGLT2s, non-steroidal mineralocorticoid receptor antagonists, and GLP-1 agonists. So we have a totally different world. But also what I'm going to highlight, screening for the presence of this asymptomatic problem, which is CKD in type 2 diabetes, is suboptimal. Only between 40 to 50% around the globe are screened. So first of all, we need to screen for the presence, and then we need to treat.